Okay, let's get started. Hi, everyone. Welcome to this educational Learn with the Leaders event presented by the Borland Groover Research Department. It's my pleasure to welcome Dr. Corregidor, who will be presenting on cirrhosis this evening. Please stay with us to the end of the presentation for a Q&A session with the expert. Dr. Corregidor?
Yes. Hi, good evening. My name is Dr. Corregidor and I work at Borland Gruber Clinic. I'm a gastroenterologist with a specialty in hepatology, and that's also my main interest. I really enjoy to treat and see patients who have chronic liver disease or acute liver problems. But today we are going to try to understand and learn about cirrhosis. I'm sure that word has been in the conversations at some point, or you may have heard of people who have cirrhosis. I think it's one of those words that kind of scare people when they listen or hear that they may have this condition. So let's learn about this particular disease, and so we can have a little bit more of the understanding. And then if questions come up after the talk, we can discuss those. Okay, so today we are going to discuss what cirrhosis is about. As we mentioned before, cirrhosis is a word that, people are scared of hearing it. I think it's also because there is no a good understanding of what cirrhosis means. And so I think with this, we are going to try to help to understand cirrhosis and learn about it. And what are the things that we can do about preventing or helping with that, diagnosing them, treat those patients, and being aware of the potential complications. So what is cirrhosis? Cirrhosis is the final histological state of liver disease, meaning that after ongoing inflammation on these different liver disease, the cells that they are in charge of causing scarring or fibrosis, which are called stellate cells, those are stimulated by the inflammatory process and mediators over the years. And those cells, once they become myofibroblasts, they will produce fibrosis or scarring for you to understand. So when there is a replacement of the hepatocytes and liver cells by these scarring or fibrosis tissue, this is part of the process called cirrhosis. Obviously, there are different diseases which can bring to cirrhosis. Some of them can go faster and develop cirrhosis in a much shorter time, as I was mentioned before, like for example, autoimmune hepatitis, when there is an acute flare-up of that disease in which their immune system is fighting your own liver, it can cause severe inflammation, almost precipitating an acute liver failure in which there is necrosis and destruction of the liver cells that they are very fast replaced by this scarring tissue. Those are patients who can go from inflammation to cirrhosis in a very short period of time. Now, there are majority of the liver disease, it takes years to decades to develop cirrhosis since the beginning on the disease. And especially when you treat the cause of the liver disease, you have to prevent the rapid process into cirrhosis or complications of the cirrhosis. So now, what are the causes of cirrhosis? Liver disease in general, multiple of them can cause cirrhosis at the end of their process. So the most common cause of liver disease that you are aware, I'm sure, is alcohol. We know chronic alcohol use or abuse can take to cirrhosis in some patients. It is true that for women, it takes much less amount of alcohol to use to develop cirrhosis compared to men. So like, for example, 20 grams of alcohol daily in women overall over time can take to cirrhosis. In men, they require 30 or more grams of alcohol on a daily basis to develop cirrhosis. So a second most common cause of chronic liver disease and cirrhosis ultimately is chronic viral hepatitis, which the most common ones being hepatitis B and hepatitis C. There used to be a few years ago in which hepatitis C, chronic hepatitis C, was the most common cause of liver transplantation. Fortunately, over the years, we developed, or they have developed, very smart people develop treatment for chronic hepatitis C. And nowadays, very rarely you can develop cirrhosis from this virus, because as soon as we see that there is an infection of that, we can treat the patients very successfully with oral medications in a short period of time. Now, chronic hepatitis B is also a common chronic liver disease. It's more common in certain parts of the world, like Asia or Eastern Europe. But we do have chronic hepatitis B here, especially because we do have immigrants from those areas as well as from Africa. The problem with these two diseases is that they, for the most part, they don't give you any symptoms. So usually it's recommended to check for the, checking for antigens and make sure that if you have been exposed to those virus, as I mentioned, because majority of them, they may not give you a symptomatology. So chronic hepatitis B and C being another cause of common cause of chronic liver disease. And then one of the most present affections of liver disease is nowadays, over the last 2 decades, is metabolic dysfunction, steatotic liver disease. So those are patients who have metabolic syndrome. They tend to have diabetes. They tend to have obesity, hypertension, hyperlipidemia. They have, especially is the visceral obesity, meaning the fat that is around the belly, the one that it causes chronic liver disease. So those are patients who up to a point, they will develop cirrhosis of the liver if they don't take care of this particular disease. That means taking care of the diabetes, taking care of losing weight, taking care of the cholesterol and triglycerides, as well as the hypertension. Those are patients who nowadays they are, especially for women, is the most common cause of liver transplantation. And this is why we have such a awareness of this disease now, that everybody that has those metabolic syndrome conditions should be checked for MASLD or metabolic dysfunction, steatosis of the liver. So there are other reasons and causes for chronic liver disease. Some of them are genetic, like, for example, increased amount of iron absorption, which is called hemochromatosis. Those are patients who have high levels of iron in their blood. And again, sometimes they are diagnosed by abnormal liver function tests in which they have increased amount of iron in their system. Again, this is a genetic disease. There is another disease in which there is accumulation of copper. That's called Wilson's disease. It's a much more rare condition. Then we have autoimmune liver disease, as I was mentioned before. So this is an autoimmune condition in which your own immune system is fighting your liver. Usually these patients present with abnormal liver function tests. And again, if it's not taken care of at the promptly manner, these patients will develop cirrhosis. Again, there is multiple other etiologies, alpha-1 antitrypsin deficiency, and other disease that it can over time develop cirrhosis. So how do we divide cirrhosis? Is everybody who has cirrhosis present in the same way? No. Cirrhosis is has a spectrum of manifestations, meaning there are different degrees of cirrhosis. We have the early stages of cirrhosis. That's when anatomically speaking, we know the liver looks bumpy, nodular, and if you do a liver biopsy, you see these septa of fibrosis in which, they develop these nodules, and is a connection of a septa between the different portal tracts. Thus is a histological diagnosis, but if you look at the liver enzymes, these patients may even have normal liver enzymes. They don't even know they have cirrhosis unless they have done any kind of x-ray, like an ultrasound for other reasons, maybe abdominal pain, or they have done a CAT scan and they describe a nodular contour of the liver. This is how they get diagnosed, because they don't have symptoms. And this is what is called compensated cirrhosis. That means that the liver is nodular, but it's still functioning because we still have enough of liver cells called hepatocytes that they are able to function and do all the tasks that the liver is supposed to be doing, like keeping the albumin level, which is a protein, that keeping the bilirubin in normal levels. There is no abnormality on the coagulation pattern. So this is what we call compensated cirrhosis. As the disease can progress, and especially if you don't take care of the main reason for the liver disease, or if you keep drinking alcohol or keep using medication that can affect the liver, like herbal supplements, these patients over time, they will start developing what is called decompensated cirrhosis. What does that mean? That means that the disease has been advancing more to the point that you are losing more cells, more hepatocytes. The tissue, the normal tissue of the liver, start getting replaced by more fibrotic tissue, meaning fibrosis and more scarring. So those are patients who start having obvious manifestation of advanced disease. They start having fluid in their belly. They start getting increased abdominal girth, and this is called ascites. And the reason why usually is because they have an increased pressure in their venous system inside of the belly, the main portal vein, which is the main vein that brings blood into the liver. So they also start having low albumin level. The liver is not able to keep up with the synthesis or formation of albumin. So that tend to bring fluid outside of the venous system. So they start developing fluid in the abdominal cavity. They also develop lower extremity edema. Another manifestation of the compensation is that that portal vein, that it gets engorged, and the blood supply into the liver gets kind of stunk. It can develop clots in the portal vein. That's not unusual on cirrhotic patients. Some of them, they need to be placed on anticoagulants so the clot doesn't keep getting bigger and bigger. And especially for those patients who may be candidate for liver transplantation, we want to avoid any larger formation of clots in the portal vein that it will preclude from having a liver transplant in the future. We also, these patients over time, they can develop engorgement of the esophageal veins that normally when you do an endoscopy, don't usually see them. Those patients, they have big veins that they can burst, and they can cause a upper GI bleed with vomiting blood and having black stools. This is a very serious condition in which the mortality is pretty high for those patients. That is why whenever we know that patients have already more advanced disease, we try to do endoscopy as just to see what is the grade of those esophageal veins or varices. And if they are grade 2 or above, we try to put rubber bands so we decrease the pressure on those veins. So we try to avoid the burst of those veins and cause a massive GI bleed. Other decompensation symptoms are when the patients start developing confusion. This is called portal encephalopathy. As the liver is losing hepatocytes, which are the ones that they keep up with the function of the liver, they are not able to metabolize the toxins that our own body produce, and even medications, they cannot get metabolized. So we start having an increased ammonia in our system to the point that patients start getting confused. They can even become comatose. So those are already signs of decompensation, because as I mentioned, the loss of hepatocytes have caused the dysfunction and not able to keep up with the function of the liver. Obviously, as the disease keeps progressing and goes into the later stage, they have recurrent decompensations, episodes, GI bleeds, confusion, coma, and those are patients that go into renal failure as well. They are not able to take only water pills to take care of the fluid in their belly, because as soon as they start having more water pills, the sodium goes low, they start getting into renal failure. So this is just when the last stage of the disease, and this is called end-stage liver disease. Those are patients that if they don't receive a liver transplant, they will die. So these are the stages of cirrhosis. So we go in a spectrum from compensated, in which the liver is still working, the patients are looking good, to the compensation, and finally they ultimately need the extreme need of the liver transplant if we want to keep those patients alive. So what are the symptoms of cirrhosis? we kind of mentioned some. So it depends. If you are a patient who have compensated cirrhosis, you may have no symptoms. I mean, you may feel a little bit more fatigue, more tired, which sometimes is difficult because that's a very inspecific symptom. Those are patients who may have already other medical problems. So it's difficult to know, is that the cirrhosis causing this? Is the the diabetes causing this? Is the fact that they are not in good shape? So then they don't exercise, they are older. So, but for the most part, fatigue could be one of the major symptoms at the beginning when the disease is in the early stage. As we advance into the disease, obviously, or if they develop a significant ascites with fluid in their belly, they can have abdominal pain because the fluid could even get infected, which is again is also a very serious condition. So anybody who has ascites and they have a significant abdominal pain, they need to have the fluid examined to make sure they have an infection called spontaneous bacterial peritonitis that it has a high mortality, and they require immediate antibiotic and albumin infusion. So, but again, those are more symptoms as the disease keeps progressing. They can have a loss of appetite. Sometimes the gastric emptying decrease on patients who have cirrhosis, more advanced, and so they don't eat as well. They also they lose their papilla taste, so the food doesn't taste good for them. So that can contribute to a loss of appetite as well. And as we mentioned, they can develop this fluid around the belly, lower extremity edema, confusion. So those could be symptoms of more advanced disease. As I mentioned, originally patients may have no symptoms. They are walking around and they may have cirrhosis. They may not even know about it. And this is the importance of trying to make sure that any indication that patient may have chronic liver disease should be evaluated and treat their conditions. So just to repeat a little bit again, complications of cirrhosis, we see them again when the liver start getting more affected, when there is no much function of the hepatocytes because they are dying, and we are replacing this by the fibrous tissue and fibrosis, more advanced. Those are patients, as I mentioned, portal hypertension with the increased pressure on the portal vein, and the consequences of everything is backing up because the liver is so scarring that the blood flow cannot go through the liver easily. So the blood back up and it creates an increased size of the spleen. That's why patients who have cirrhosis, they have low platelets because those platelets die in the spleen because the spleen is engorged, so they end dying. So those are patients who also tend to bleed more because of the fact that the platelets are low in their blood supply, as well as also they have issues producing coagulation parameters. So those are patients who may develop GA bleed, as we mentioned before, because of the engorgement of those veins in the esophagus or in the stomach. They develop ascites with the abdominal fluid collection. They get confused and even comatose. One of the also early manifestations of cirrhosis as the disease is progressing, before they even become confused, is that the patient notice that they are not able to sleep so well at night. They tend to sleep more during the daytime. So they have a change in the sleeping pattern. So that's already kind of a manifestation that this patient may have hepatic encephalopathy. And then a very important thing, which is one of the reasons why we said to everybody who have cirrhosis, even if it's compensated, they have a higher chance of developing liver cancer. So that's why there is a screening surveillance for hepatocellular carcinoma, which is the main liver cancer in patients who have cirrhosis, that we recommend to be seen every 6 months. And we check the liver by blood work. We do a tumor marker called alpha fetoprotein, and we also check by imaging the liver. We can do it with ultrasounds or we can do it with MRI. Sometimes I alternate those because obviously MRI is a better choice, as you can see the liver better and you can find small lesions faster than an ultrasound that it can be dismissed. So liver cancer is a major risk on those patients who have cirrhosis, compensated or decompensated. And this is important to let the patient know that it's important to come every 6 months and be examined and check for that issue. I know some patients confuse cirrhosis, which is called stage 4 fibrosis, and we can explain what are the different stages, but stage 4 means cirrhosis. But stage 4 cirrhosis doesn't mean you have cancer. It's just that the liver tissue has been replaced by scarring. Now, it is true that, as I mentioned, cirrhosis is a good culture for liver cancer. And that's why it's important to be followed every 6 months and do blood work and imaging. So how do we make the diagnosis of cirrhosis? Well, it usually can come in different ways. I do have patients who come because they did the gallbladder surgery. The surgeon was inside the belly and they see that the liver was bumpy and nodular. So they do a liver biopsy and show that the patient has cirrhosis. So this is a way, and this is mainly the gold standard. You know, a liver biopsy shows you, for the most part, if you have cirrhosis, because it will see the connection between the portal tracts in form of nodules from the fibrosis and the tissue and the scarring of the liver. Now, it is true that a lot of the patients don't come with liver biopsies. They come because the primary care physician ordered an ultrasound or a CAT scan, as I mentioned before. And on the CAT scan, they describe nodularity of the liver. Maybe the spleen is bigger in size. So those are potential diagnoses or symptoms or signs of cirrhosis. So imaging is a way of knowing if a patient has cirrhosis. CAT scans or MRIs better than ultrasounds. Ultrasounds are not very clear. It can tell you that the liver looks a bit more horns, that the surface of the liver is a little bit irregular, but a CAT scan and MRI is a better test to say that the patient may have cirrhosis. Also by the clinical aspect of the patient, you know, it can come with ascites or with lower extremity edema. And if you look at the blood work and you see that their albumin level is low, that the bilirubin is elevated, that their INR, which is one of the blood tests that talks about coagulation, is prolonged, all these things along with the physical examination and the imaging of by CAT scans or MRIs already can help you to make the diagnosis of cirrhosis. Now, once we know somebody has liver disease, we need to know why. What is the cause of the liver disease? Because if the patient has evidence of cirrhosis, especially early cirrhosis, you can put the patient on treatment. Like, for example, for hepatitis B, okay, somebody come and they said, oh, we found out that this patient have hepatitis B. You check and see if the patient have cirrhosis, and you start doing treatment. These patients can improve, and part of the fibrosis can improve and decrease by just putting the patient on the right treatment based on their cause of their liver disease. Same way with autoimmune hepatitis. If we notice that the patient has evidence of autoimmune hepatitis, we check on the fibrosis stage and it has an advanced fibrosis stage, which may mean like F3. You can improve the fibrosis stage by start treating the actual disease, in this case, the autoimmune hepatitis. So all these things help to, and we use tests to evaluate the stage of the disease. Is that advanced disease? Is that a moderate fibrosis? Do they have already cirrhosis? By putting patients on treatment and taking care of them and telling them to avoid certain things, we can improve the fibrosis and the scarring of the liver. That's something new compared to years ago, in which we thought that once you have a scar, the scar doesn't go away. But now we know, for example, patients who have MASH or the metabolic dysfunction associated steatohepatitis, that if you put those patients on treatment, or of those patients lose significant amount of weight, usually about 10% of their weight, they can improve not only on taking away the fat of the liver, but also improving the scarring of the liver and improve on the fibrosis state. So what is the treatment? How do we manage patients who have cirrhosis? So mainly, first of all, find out what is the cause of the cirrhosis, so you can put a treatment for that. If the patient is drinking too much alcohol, they need to start modifying their lifestyle. They need to stop drinking alcohol. It's not about, some of the patients will say, how about if I just decrease and drink less? No, once you have cirrhosis, you have to stop. Otherwise, the process of the disease will keep going fast. And this is our patients who in less than 5 years or 3, they may develop decompensation of the disease and even require a liver transplantation. As I explained to the patients too, if they are drinking, maybe they will never get a liver transplant because unfortunately we don't have many organs available that we can be transplanting everybody. So lifestyle changes for patients who have MASH or the metabolic dysfunction associated steatohepatitis, we tell them to lose weight, as I mentioned just a minute ago. If these patients lose a significant amount of weight, which they should do by eating less amount of carbohydrates, avoiding fried food or fatty food, making sure the exercise, or even being placed on treatment. Now we have medications for fatty liver, we have Rezdiffra, we have Ozempic, and they are investigating multiple other drugs. Those are patients who may benefit to the point that they can improve their histology and being able to halt the process of going into cirrhosis. So those are lifestyle modifications, exercising, diet, and avoiding alcohol, avoiding taking, believe it or not, I know patients think that because something is natural like herbs or vitamins that they are related to plants, they are healthy and good for your health. But for the liver purpose, certain herbal supplements could be very toxic. I recently saw a lady who came to me with jaundice. Her liver function tests were really high. And the only reason why this lady developed that is because she was taking a herbal supplement that she was told it can improve her immune system. So obviously, as soon as she stopped this supplement, her numbers have been getting better and she's improving. But herbal products sometimes can take patients to acute liver failure and dying from that if they don't give in a transplant. So the next thing is obviously to treat the cause of the liver disease, which is the medical management. So if you have autoimmune hepatitis, you should be on prednisone or Imuran, which are immunosuppressors. If you have hepatitis B, you should be on an antiviral for hepatitis B, like entacavir or Venlidi. If you have chronic hepatitis C causing the disease, you should be on an antiviral for hepatitis C, and we can treat and get rid of those hepatitis C virus nowadays. So different disease requiring different treatments. So as soon as we find out what is the cause of the liver disease, we should start the patient on treatment to try to see if we can prevent for further deterioration of the liver. Certainly, liver transplantation is the last resource for patients who goes into end-stage liver disease. We send patients to be evaluated for transplants when we start seeing that they get worse and they have repeated decompensation episodes. There is a number called MELD score, MELD, and that's based on sodium level, kidney function or creatinine level, INR, which is the coagulation, the albumin, the bilirubin, the age of the patient, and that gives us a number. Once the number goes up to over 15, that indicates that the patient may benefit for a liver transplantation. And unless there is no other contraindications, like the patient is too old or the patient have major cardiac issues that will not be able to tolerate the surgery, we tend to send those patients to a liver transplant center so they can be evaluated for possible transplantation. In the meantime, when the patient is getting decompensated, we use, water pills to help with the fluid in their belly and the edema on the lower extremities. We use certain medications like lactulose, which is a syrup to help with the ammonia level. On patients who have hepatic encephalopathy, we also use an antibiotic called cifaxan, which helps with that as well. We do endoscopies to try to band esophageal varices if they are getting engorged before they cause a massive GA bleed. We can also use medications like carvedilol to help decrease the size of those esophageal varices before they bleed as well. So there is a whole algorithm on how to treat these patients, how to follow those patients. And again, very important, every 6 months surveillance for hepatocellular carcinoma is a mandatory thing for patients who have cirrhosis, even if they are compensated. So we know cirrhosis is a disease, is a progression of all majority of the chronic liver disease will end in cirrhosis if we don't take care of that. And even some of them, like certain disease, even if you do medication for them, they still over time will advance and get cirrhosis with replacement of the hepatocytes by fibrosis tissue and scarring. The important thing is to recognize disease that can be treated is to teach and educate the patients about taking care of themselves. There's things that they are in their hands, like do a good lifestyle, eating healthy, exercising, keeping away of alcohol or toxic drugs or anti-inflammatories that they can make the decompensate the disease more and affect the liver and the kidneys. Trying to avoid herbal supplements that we don't recognize the herbs or roots as they can be as toxic to the liver. And just make sure that you follow what the doctors tell you. Come every 6 months, call me if you notice any difference. This is very important. So prognosis is also depending on how the patient is involved and educated, and certainly is depend also on the etiology of the liver disease. So we can help with patients who have chronic liver disease before they reach a major stage on cirrhosis. We can follow those patients. It's important nowadays to, when patients have different liver disease of different etiologies, we can evaluate them before before they get into a major complication with tests that we don't require even to do liver biopsies. Those are called NITs or non-invasive tests. Those are made of certain blood work like FIB4, in which it counts the AST, ALT, which are the liver enzymes, the age of the patient, the platelet level, and we can see what is the number. If the number goes between 1.3 and 2.67, that means those are patients who may have more fibrosis or scarring than we want. So we have other tools to help to evaluate those patients, like for example, FibroScans. FibroScan is a vibration, transient vibration elastography that use waves to see how much the liver is elastic or stiff, and that will help us to determine what is the fibrosis stage. Fibrosis goes from 0, meaning no scarring, to 4, which is the cirrhosis. Stage 4 is cirrhosis. So we want to catch patients at level before they reach cirrhosis. So if they have fibrosis stage 2 or 3, is a matter of start working with them and try to prevent the further worsening of the disease by doing treatment in case of like MASH or metabolic dysfunction, steatohepatitis, or viral hepatitis, or primary biliary cirrhosis. Again, any particular disease can be evaluated before we reach the way of developing cirrhosis or complications of that. Certainly patients who have cirrhosis should be followed very closely. And this is what we are here. We are also now, again, evaluating medications that can prevent and help with the fibrinolysis, meaning decrease of the scarring of the liver. And I'm sure in the near future, we may even be able to revert majority of the scar of the liver. And this is what we are looking forward in research studies that we do here at Borland Gruber. This is the end of my talk. If you do have any questions, please, I'll be here in case you need some assistance with those. I appreciate your time here. Thank you so much.
Thank you so much, Dr. Corregidor, for that informative presentation. I just want to mention, if you're interested in a complimentary FibroScan or liver screening, or learning more about clinical research for cirrhosis, please feel free to reach out to Borland Gruber Research. We'd be happy to coordinate any appointments that you would like to schedule. And we will also be emailing you this presentation just in case you missed anything. And we'll move to the Q&A session. If you have any questions, please put them in the chat. If you think of something later, please feel free to also reach out to our team. Like I mentioned before, we will be sending out the presentation, so you can also, send a message in the contact information that will go out to you. Thank you again for attending. For additional educational events or resources, please visit the Borland Gruber Research website at ebgcr.com. Thanks again. And I don't see any questions right now. So I'll give it just a minute and then we'll close, because I know we're a little bit over right now. So I do appreciate you sitting on with us, and I do appreciate Dr. Corregidor's presentation. That was wonderful.
Thank you so much. Okay. Platelet count low.
Mhm.
Okay. So, okay, how do, what is the, I guess I see some questions. Platelet count low. What does that mean? What is the question? Somebody mentioned also about a MELA score of 9. Oh, I'm being monitored. Okay, what are the questions? I'm getting confused here.
Yeah, so one of them was platelet count low. Do you want to expand upon that? I can't quite
Okay,
see.
I mean, yes, usually the platelet count should be above of 150. Usually when the patients who have more scarring and advanced fibrosis, we can see that the platelet count start getting in the low side or borderline. That may indicate, especially when you see other things along with that, you may consider that the patient may have more advanced disease. And that's why you may start getting concerned about having more fibrosis or scarring, maybe an fibrosis stage 2 or I'm sorry, stage 3 or even 4 cirrhosis, because that's when the spleen gets enlarged. And this is when it sequestrates the platelets. So usually those are patients who have more advanced disease. So obviously low platelet count is an indicator that we may need to start looking for cirrhosis.
Okay, and then we also have I have a MELD score of 9. Is that bad?
It's better to be lower, but 9 is still not even considered for a liver transplantation. It has to be above 15 to even be considered for being placed on the list.
Okay. And then I have cirrhosis of the liver without ascites right now. So what's the next, I guess the next step for this person?
So I'm sorry, what was the question? I have cirrhosis?
They have cirrhosis, but they don't have ascites right now.
Okay. So
Mhm.
again, if you have a compensated cirrhosis, meaning that the only thing is that your liver is nodular, bumpy on an imaging test, but your liver tests are completely normal, meaning that the liver is still able to make all the functions, then the only thing you really need to do is make sure you eat healthy, exercise, do not drink alcohol, make sure you don't overdo ibuprofen, Motrin, and for sure, make sure that you follow with a GI or liver doctor, because every 6 months you should be checked for liver cancer or hepatocellular carcinoma with blood work as well as imaging tests.
Great, thank you. They say their blood work is fine. So,
Okay.
but every 6 months is, thank you. I think that's all that we have. Thanks again for everyone for attending, and we'll be sending out this presentation to you shortly, and have a great evening.
I appreciate that. Thank you so much.